guys, welcome back to the Pulling Curls podcast. Today we are talking about informed consent in labor and delivery, so let's untangle it. Hi, I'm Hillary, a serial overcomplicator. I'm also a nurse, mom to 3, and the curly head behind Pulling Curls and the Pregnancy Nurse. This podcast aims to help us stop overcomplicating things and remember how much easier it is to keep things simple. Let's smooth out those snarls with Pregnancy and Parenting Untangled, the Pulling Curls podcast. Today's guest is a certified nurse midwife in Pennsylvania. She actually had 5 kids of her own, then went back to school, became a labor and delivery nurse, and then became a midwife. I want to introduce today's guest, Julie Pyle. Hey, Julie, welcome back to the Pulling Curls podcast.
Hi, Hillary. It's good to be back today.
So we're on this longer form content, and when I was thinking about who I wanted to have a guest, Julie definitely came to mind because I think you have a lot of great information as someone who's had multiple babies, someone who's been a labor nurse, somebody who is a midwife, of things that people are actually thinking about as they deliver their baby. And of course, it's sort of different, like locationally, because I've delivered in the West, you're in the East. So I'm just excited that you're here. And today we're going to talk about informed consent. So let's first define what is informed consent.
Yeah, I think informed consent is really a hot topic right now in the medical world, and especially in labor and birth, because really once we define it, you'll understand why. But it's super important for us to have a grasp of what is going on with our bodies in any sort of medical scenario. So informed consent really has 5 components. The first one, which seems pretty obvious, but does the patient or do you understand the information? That doesn't seem like something we'd have to define, but sometimes as medical providers, we get talking and we don't have the right words so that the person understands what we're talking about. So patient has to understand the information. The second part of that is it needs to be without any sort of coercion or undue influence. So you have to be really objective in the information you're giving and not try and sway somebody because of what you think should happen as the provider. Really, all the information should be disclosed about the risks, the benefits, the alternatives, the right to decline whatever treatment we're talking about, and knowing what the potential complications are either way. That's not always a simple conversation, but a really important one when we're talking about informed consent. And the right to refusal is really the 4th point. And then the last piece of all that is documentation, that it's happened some way, shape, or form. Sometimes that's an already pre-printed form that people just fill out and sign. Sometimes it can just be documented in the medical notes, but somehow there needs to be something written that informed consent was discussed and what the outcome was.
That's actually one of the first things I learned as a nurse. Back when we had paper charting, we had a little stamp about informed consent, and then the provider would sign it before a C-section. And I think they did it before an epidural. Now, it is tricky because they're like, well, we want informed consent on everything. And let me just remind you, if we did informed consent in our lives, I don't know if our car would ever get going, right? If it gave us all the things that could happen to us in the car. So we as providers tend to keep informed consent to the important things, but you're always welcome to ask for informed consent, right?
Absolutely. I think that's a big piece of, as the patient or as the person receiving care, anytime you feel unsure about what's happening, just a simple question of, can you explain the risks, the benefits, and the alternatives to doing this to me? Because then that should give the provider the clue that okay, this person needs to understand more.
Yeah. Why do you think we're not good at giving it in the hospital? Because I'll say, Julie, my mom was just in the hospital having ankle surgery, not having a baby, thank goodness. And it's surprising. It's just people aren't great at it because I think they think this is obvious, right? For her, it's been a long plan of care, several things. And so they're just this is obviously the best option for you. But it is annoying that they aren't this is why.
Yeah, I think we are in a hurry always. Our lives are busy, right? And so to think about taking 5 to 10 minutes with every single patient to explain every single procedure can feel overwhelming from the provider side. But that doesn't mean it's not important to do so. But I think busyness and time is a huge part of it. I think there's a component that if we explain too well, that people may not choose to do the treatment or may not choose to have the surgery if we're really honest about what could happen. And of course, as a provider, we sort of obviously count on people doing these things as part of our jobs, not counting on it like they have to do it so that we make money, but just obviously if our schedule doesn't have procedures on it, then we wouldn't have a job, right? And I do think it comes down to we don't do a good job of like really explaining things in a way that doesn't include our values and preferences, like, oh, I would do that, so you should do it, and we just leave it at that. But that's my
Yeah.
perspective on what's going on.
Yeah, two thoughts. Oh, so we used to have an anesthesiologist who they come and they give informed consent. Nobody seems to remember it, which I can't blame you because you're in pain when you get the epidural informed consent. But they always come in the room and they say, there's a risk of a really bad headache. There's always a risk of infection or blah, blah, blah. And then he always ended it, or you could die. And I would see the patient's eyes get really, really big. And so I started to cut, before he came in, I said, just so you know, his informed consent will end or you could die. And I've never seen anybody die from an epidural, but he's just giving you all the things. Not every
Yeah.
anesthesiologist. Do you ever hear that?
We have a couple that go so in depth with their informed consent, which again should not be considered a bad thing, that even the patients are like, yes, whatever. I'm ready. Like, give me the epidural. Like, I don't care what you're telling me right now. So I think there's both ways. Like, you can do too much and people stop listening,
Yeah. And you have to remember that if your oven or your car gave you informed consent, the full informed consent, it would end with, or you could die, because obviously ovens can be very unsafe, especially in the hands of me. Or my car, with my teaching my 15-year-old how to drive, it should yell that at me, right, when we get in the car. So sometimes patients are overwhelmed, and some patients do not want it at all. They do not want to hear all the risks and the benefits. They don't want to make a choice. They literally just want to hear whatever the provider thinks is best. That's what they want to do. And I think that's valid. And I think you could even stop them and be like, whatever you think is best, I'm on board with, if it's really starting to freak you out. Because a lot of patients will be like, maybe I don't want an epidural. And I'd be like, are you sure? Like, the risk was always there. You knew that there was a risk of dying with anything we were doing today. And then they're like, I guess. And then they're just freaked out, right?
Yeah. It's funny you mentioned that. I did a small little couple of months in the South as a nurse, and there was very much a mentality regionally, like, if the provider comes in and says this is what should happen, I'm going to do it. Like, they didn't ask questions. They really didn't care about informed consent. The provider knew best, and I'm going to follow it, which has risks in and of itself, right? So it's very interesting that just regionally that can vary quite a bit of how much information people even want to know.
Yeah, and overgeneralizing a whole bunch. It definitely varies depending on your age, sometimes your nationality. I feel real bad when we're trying to give informed consent and we're giving it through the translator line, and I'm never sure that the people are really truly understanding what the informed consent is. They're trained interpreters, like that's all we can do. But sometimes those language barriers, just not interested in maybe learning about their own care because they have so much going on in their own life at home. Things like that can really affect it.
Interestingly, when you look at ACOG, which is the governing body for obstetricians, and also ACNM, which is the governing body for certified nurse midwives, they have very clear statements and very clear information on what informed consent is, and that it should be happening in every instance humanly possible, that we should be providing that education, and that it's really being much more recognized and taught in the coursework for these up-and-coming physicians and midwives as well. And that should tell us that it's an important topic.
And some people call it different things. I noticed when I was at the A1 convention, they have a different word that they use. And I can't remember what it is, but it's basically the same thing.
I know we talk about shared decision making. I don't know if that's what you're
shared
thinking about.
Making. Yeah.
And really that's the process of the informed consent and making the future plan, is that shared decision making. I do feel like they are used synonymously sometimes, but both are components for sure.
Yeah. Okay. So what should people be looking for informed consent on? Because I know a lot of people are like, well, you should give informed consent before you get the IV. You should be giving informed consent before you take a blood pressure. And I was like, okay, I don't know that I can do it for a blood pressure. Also, if I was giving it for every single little thing, sometimes they might skip the really important things, right? I think we should be giving it briefly for maybe an exam, like a cervical check, just to be because a lot of times the alternative is that we wait.
There's this weird, I think, dynamic because some of that, I think for us that do it well, it's respect. Like, I'm respecting this person I'm taking care of, and I'm going to let them know I'm going to put the blood pressure cuff on, just telling them that, is a type of informed consent, right? Because they may not know that that was your next step, so you don't want to freak somebody out. Or like with the cervical exam, giving a little bit of warning and a little bit of notice about what's going on. I think that's just respect, but it also can fall into the category of type of informed consent.
Yeah. And, like she said, it's not always going to be like, today I'm going to discuss the risks, the benefits, and the alternatives of this cervical exam. It could just be like, hey, your provider was wanting us to check you every couple hours. What do you think about doing it now? If you want to wait, we could do that too. We just kind of want to see what your cervix is doing. We're inducing you. We want to make sure we're doing our job. That is an informed consent. It just didn't be like, I'm going to go through the risks and the benefits. Yeah. Because it's awkward. Like, we want to just have a conversation with people. We don't want to be like checking boxes all the time through our care.
Yeah. And I think like I had a good example in the last couple of weeks of an induction that I was managing. And we know as labor nurses and providers, like if we get to the point that breaking the water is a good option, like it's going to make labor faster for somebody, especially that's had a baby, right? But I gave that informed consent and that patient did not want water broke. And I said, great, you let me know when you're ready for that. I'll ask again at some point, and instead of a baby probably in 1 to 2 hours from that point, it was like 7 hours from that point. Is there anything wrong with that? Probably not, and she can fully say that she was in charge of that decision and was able to make the plan for herself that way. Looking back, I think she would have probably liked me to break the water earlier, and we would have known that she could have had a baby sooner, and that's a good example of like, she chose to decline and that was okay.
Yeah. I did that same thing with my last baby. I didn't want to have my water broken because I was sure I would end up with a C-section if they broke my water. And then they broke my water finally at like 6 centimeters and I had the baby like half hour later, but I had made the choice. I had driven the car and I drove the car very, very slowly up until that point. Yeah. And
on the flip side, if you had been forced into a decision, of like, or this patient, if she had said, I don't want that. And I said, well, we're going to do it anyway. Then that her whole experience is different. And then it becomes birth trauma or it becomes like, a potential lawsuit potentially, right? Like those are things that can happen if that doesn't go correctly.
Or my favorite, the doctor doesn't even say anything. He just goes, hand me the amni hook. And I go, oh, did you want to have your water broken, Jane? And he glares at me and I'm like, don't you think we should ask her?
Yep, absolutely. And that still happens. I think it's happening less, but it still happens.
Yeah. And pro tip for everybody out there who's going to have a baby, when they go to do a cervical exam, a doctor or a midwife, because labor nurses officially are not allowed to break water, you can always ask, are you thinking about breaking my water while you're in there? Especially for the hospital. They're not going to do it in their office, hopefully. But yeah, to sneak it in. We don't like to sneak things.
I think that for labor and birth specifically, a really classic example, and one, again, I hope is happening less, but it still occurs, is the episiotomy, right? That becomes like a big topic of debate. And like if a doctor or provider or midwife says, oh, we're just going to make a little extra room to help baby get out faster, that's not informed consent, right? That's not explaining what's happening. That's not giving the patient a true option to decline or accept. But that still happens, versus like, hey, this is what I'm seeing. I can do this procedure. These are the risks. These are the benefits. Would you like this, to be part of your care? That's a really classic one that we're going to continue to see. But I think as labor nurses, you really have seen that a lot more. And it makes you nervous when that's happening.
So that is tricky because there are points in time where they're like, I need to give you a cut when the crap is really hitting the fan or whatever. And hopefully providers have talked to you while you're in the office about it. I don't do people do this anymore? When I had my first baby, they went over like probably 30 weeks. They went over, are you okay with blood products? We might need to do an episiotomy. We might need to do an emergency C-section and we might need to take your uterus. Like they went through all like 4 of those things just to kind of let you air your thoughts on all those different kinds of things, right? Do any providers do that anymore?
I think it's really like provider and facility dependent because I have seen that still happening, and then other places that like literally nothing's talked about ever. So varies quite a bit, unfortunately.
Yeah. And if you're having that discussion with your provider, I think it's A-okay to say, you know what, if me or my baby's life is obviously in jeopardy, we're A-okay with an episiotomy. But everything up until that point, I would really like you to stop and say, do you want me to do this? And that, I'm just here to say that does happen. Sometimes they're like, you could keep pushing for another half an hour, or I could give you a little cut and we and we could have this baby sooner. And I think that's valid. I mean, I think that's true informed consent, because maybe the woman really values just getting that baby out. She's so tired and miserable. And if that provider, experienced provider, knows that a cut will help get the baby there sooner, she's like, knew it. I'm over this, right? Or
Yeah.
she's like, no, I really love my perineum. I want to try and keep it as intact as possible. I want to push until my eyeballs fall out before you cut me, right? Everybody, there's two different people.
Truly, I think that's the part of informed consent we don't often talk about, is that somebody may want the more invasive thing, and they may really feel like that's better for them. And sometimes we don't even talk about it, so then we really haven't given them all of the information to make a decision. We've talked about this previously on induction podcast that we did, right? That somebody may have a lot of really valid options for desiring that higher intervention induction at 39 weeks as soon as humanly possible, even though that might not be what the majority of the people would choose.
Yeah. And I actually have a super conservative friend who home births, and she was like, I don't even understand why they give women the option. And I was really taken aback by that, because that just makes me feel like, okay, it has been proven to be safe, at least for the most part. It may increase C-section rates, whatever we want to talk about the Arrive trial. It has been proven that it really doesn't ultimately hurt mom or baby to have an elective induction at 39 weeks. And we, as sentient people who get to make choices for our own bodies, really should be able to make that choice, not just the provider doesn't make that choice. Now, of course, if the hospital's too busy or things like that, then we don't get to make that choice. I have people all the time that are like, no, they will not induce electively before 41 weeks, which I'm like, whoa. It's crazy how different some hospitals are. But what do you think on that?
About 41 weeks?
Well, no. Oh, what do you think about the 39-week induction? Don't you think we should all be... Sometimes I'm like, well, if somebody really wants to be induced at 37 weeks, it is kind of weird that we don't even give them the option. Of course, we're having to balance the thing of, prior to 39 weeks, it has been proven that maybe your baby could have a NICU stay or have ultimately bigger problems. And so we're really trying to push that off. But it does sort of bother me that if people are begging for an induction at 37 weeks, we're just like, nope, 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 nope.
Yeah, I think the 39-week discussion, again, gets really heated. And if you have 10 different providers, labor nurses, you're going to get all 10 different perspectives. And again, this is part of my informed consent when somebody's asking about it. It's like, there are things that start to increase your risk by not having a baby after 39 weeks, So we know that definitely after 41 weeks, right? Placental function declines, other things start happening that will not help a baby on the outside. But even after 39 weeks, that risk of stillbirth, the risk of preeclampsia, the risk of fluid around baby going down, all of those start to get more risky. Not significantly so. We're not talking about 50% between 39 and 2 days, but it is start to go up. And so some people even use the term risk reduction as far as what happens after a 39-week induction, that you're reducing the risk of somebody by inducing. So there's certainly a lot of discussion that happens, but we just have to respect that somebody can understand that information and then make the decision of yes or no for themselves.
Yeah, it's tricky. And everybody's like, oh, I'm going to make that decision when I'm 30 weeks pregnant. I'm like, no, you make that decision based on, what's your cervical exam at that point? If you're 6 centimeters and contracting every evening, that's a big difference between I'm close, thick, and high. I've never had a baby before. These are very different situations that we're looking at.
Absolutely. Yeah. And that's what makes it so tricky, because there's so many variables.
Yeah. So what do you think? I think this is a big one that people maybe don't get enough of an informed consent on, because they're just thinking, yeah, I want this baby out, right? Because I'm so tired of being pregnant. So what do you think are things that people should be talking with a provider so that they feel like they get a full informed consent? Because I so often hear online, my provider forced me to have an induction and I didn't want to have it, or he scared me and said I should have an induction and then I ended up having a C-section or whatever like that. What do you think people should be going through before an induction so that they really feel like they have a handle on what's going to be happening to them?
I think you have to specifically ask what the induction protocols and what the plan usually is at the facility and the provider you're using, because the way I manage an induction may be completely different from somebody else, and that can make your whole experience very different. Evidence has proven that nurse midwives as providers, you're going to have more successful labor progress in general, and that includes induction. Part of that is because we're not, and this is a very general statement, but generally speaking, we're not as tied to really specific timeframes and milestones throughout. We're going to individualize that to exactly what your body's doing, So, for example,
And a shout out for midwives because they're there. So that's how they can tailor it, right? Whereas an
yes.
OB calls in maybe every 4 to 6 hours. They're not there. They aren't kind of watching everything every step of the way. Shout out for
Yeah.
midwives, guys.
Yeah, historically and generally speaking, we're going to be a little bit more present in the care and be able to kind of doing informed consent all along the way instead of like just this one discussion, at 39 weeks right before your induction. And again, I think that's a big conversation for people who desire that is like, okay, what happens if my cervix is staying the same for 4 hours? What are you going to do? And then getting that answer. And if you're not happy with that, then you have to start making decisions along the way.
Yeah, it is true. A lot of people are really upset with their Foley bulb inductions lately because it can be really painful. Some people, that's the tricky thing, right? Some people get a Foley bulb placed and they could care less. It doesn't bother them at all. And then some people get a Foley bulb placed and it is literally the worst thing in their whole lives. They want the epidural just for that Foley bulb. And I think sometimes people forget that it's such a huge range, just like IUD placements. Like I got my IUD placed. I was like, when are you going to be done? Right. And she was like, oh, it's already in. I was like, oh, I don't have any feelings down there apparently. And so there is a huge range of how people feel different things. And the best part of informed consent is knowing that you can, you get that Foley bulb placed and it's absolutely miserable. You're like, I want to go home. I want it out. I want to go home. And that's always an option.
Yep. I think that's important, like especially for Foley bulbs. I tell people, I'm like, I think this is a good option. If you absolutely hate it, it can come out. That's the great thing about that process. Now water breaking, like we talked about earlier, can't take that back, right? So that's one that you have to be pretty sure about. I'm all about giving people all of their options and allowing them to make a decision. And there are times when they will tell me, I have no idea. What do you think we should do next? And then that's when my professional experience and opinion becomes, probably likely to what's going to happen because they're asking me that for that. And that's
Right.
part of their informed consent is that they're like, I don't know. This is a lot of information. What do you think?
Yeah, because it can feel like a deluge of information in labor and delivery. And it's okay to be like, I'm not sure what I should do. What do you think? Or if this was your choice or your daughter or whatever like that, what would you be encouraging them to do at this point? Or something I think that really helps is, I really value aiming for a vaginal delivery, right? Like that is one of my highest priorities in this delivery. This Foley bulb is hurting like a son of a gun. What do you think my best option is to try and not die with a Foley bulb, but also get a vaginal delivery and then see what your provider has to say, right?
Absolutely. Yep. We should always be open for things to change throughout the process, especially when we're talking about babies being born.
Yeah. What other things do you think people should be looking for an informed consent on?
Well, induction, like we said, that's a huge one. Throughout the labor process, breaking water, that's a big one, as well as a big topic right now is delayed versus immediate pushing. So, and then also positions in labor, I think is always going to be a big thing because there's a lot of facilities and a lot of people that don't want laboring people to move around because it makes our jobs harder. And so positions, I think, throughout labor, I don't know that that's truly like informed consent, but like if you have a provider that says you have to stay in bed, the patient, you can ask like, why do I have to be in bed? What are my other options? What are my other alternatives? And why are we doing it this way?
Yeah, I think that's a great one. And also sometimes as a nurse, I would go in and be like, okay, let's roll you to the other side or whatever when they had an epidural. And they're like, oh, I'm just so comfortable right here. And so sometimes I would go into informed consent. We're not going to be like, well, these are the risks of you staying on your left side, right? Just saying, hey, I have noticed that patients who move more during labor tend to progress a little bit better. And I would love to help you move. But if you want to stay on your left-hand side, then you can totally do that. What do you want to do, right? And that is an informed consent where I'm just saying, I think you might be better off turning, but if you want to stay where you are, go for it.
Yeah. I think one that I hear a lot is people say, oh, I don't want to give birth on my back, right? I don't want to have the baby come out on my back. But I often find that laboring people prefer that position. So I'm open to like any position. Like if you feel like you can do a handstand and you want to try pushing like that, I'll try for you, like let's go for it. But a lot of times people are trying to figure out what to do. And I said, let's try that position. A lot of people prefer it. And then they're like, oh, I don't want to change out of this position. Like I like this position. And it's the one that they thought that they absolutely didn't want.
Yeah, there are a lot of benefits to being on your back. Most of them being that between contractions, you can chill out a little bit. And the other thing with informed consent is it's okay if your provider says, I feel like I think this is the best way I deliver. If your tile man came and you were like, well, I want you to tile the ceiling, wouldn't you want him to say, I am not great at tiling the ceiling? That's not my skill set. And the same thing goes for your provider. They can say, I've delivered 99% of my patients on their back. That's delivery. That doesn't mean you have to push the whole time on your back. And I'm best at that. But if you want to try doing it squatting, I'm happy to try that. I just want you to know my A game comes when you're on your back. And I think people get mad that they're like, well, why don't you have a B game for squatting? But the reality is, I think it's great when a provider says, this is what I'm best at. What do you want me to do?
Yeah. And I think that's where you should be evaluating that relationship between provider and yourself before labor. Asking questions along the way so that you're not blindsided by something, but also so that it's a good fit and hopefully a good experience.
I think it can be really tricky. And the other thing that I don't think people understand is that in the hospital, we can give you informed consent and you can still end up suing us. And so that ends up feeling really tricky for us because, if we have a patient that we've seen is in trouble and they definitely don't want a C-section, we're hands off and we're like, okay, baby ends up having a bad outcome and we're like, well, we just informed consent the heck out of that lady. Nurse, doctor, second doctor have all come in and said, we see a bad outcome. And yet they still come back and sue us. And so that is really tricky for us as providers. Do you have any thoughts on that?
Yeah, that gets really in the weeds of documentation and being able to show that there was real good conversations. And if that can happen and the outcome was still not as expected or not great, that unfortunately gives us a little bit more clout on our side to say and I will make documentation if somebody's declining something and their risk of stillbirth is really high, for various reasons. I will put in my note discussion held about whatever it was and that her risk of stillbirth is higher if we do not do this thing, because none of us can know if that would happen. That would be the worst outcome, obviously. But it has to be really clear, on the provider side. And hopefully, if we're documenting that it was really clear, we really give the information clearly to the patients so that they're getting the information that they really need. But that's so hard because we can't predict the future, especially in labor and delivery. It gets very, very gray in many situations.
I just like people to understand that sometimes when we're going over things maybe excessively, that's part of the reason why is we're all real worried about liability. And I wish we didn't have to be so worried about it. Obviously, I wish we could just give informed consent and that would be enough and you get to make the choice that you want. But liability is a tricky part in labor and delivery, especially.
And the other part that I'll mention is that, when talking about litigation, because we work in OB, so we're going to have to talk about litigation because it's a high litigation area. But again, the research has bared out that one, midwives are less likely to have litigation on them. And two, that a good relationship with the patient, so somebody who feels like they can trust you, that you've given them information, that you've respected them as a person, are much less likely to even think about or pursue litigation. Even when there's been really horrible outcomes, if the process along the way has been compassionate and respectful, it's less likely that that's going to come to that.
Yeah. So, Julie, you are a certified nurse midwife, and we have an episode that I'll link in the show notes that we talked about the different people that can deliver your baby. And it is so confusing for people because some people think of a midwife as just Joan down the street who delivers babies on Little House on the Prairie, where Caroline would go sit with them, right? Versus somebody who, do you have a doctorate, Julie? We have to have a doctorate.
I don't.
In,
Arizona. I have a master's degree, but yes, some states require a doctorate, but
yeah,
it's the equivalent of a nurse practitioner. Yeah.
Yeah. Where you've had a residency, plus you were a labor and delivery nurse before you were a midwife. It's an extensive training. And the beauty about a midwife that I think a lot of people don't understand is you always have an OB where you're kind of we're starting to get in the weeds here a little bit. I'd like a consult with a little higher up, right? I'd like to move this up. So what's the best part of having a midwife deliver your baby, Julie, versus an OB?
Yeah. The first part of that, I think, is that the understanding that, we're not obstetricians. We don't have a physician training. We can't do surgeries, right? Yeah. But we actually manage, not all of us, it depends on our training and our experience, but most of us manage high-risk conditions throughout as well. It's not just the most low-risk person is the only one that can have a midwife as a provider. So, I will manage people with hypertension, people with regular diabetes or gestational diabetes. Like those are things that I can help manage. So we're not just like the lowest risk people that can have a baby and a TP and that's all. So we're not exclusively keeping people that have high risk conditions out of our care. We can do that. Again, there's much more of a holistic approach. So we're looking at the whole person and like you have 5 other children. How are we going to get you to twice a week fetal testing appointments, right? How is this going to work for you? Instead of just saying, you need twice a week visits, figure it out. Like we're going to try and work through, the whole scenario as well as looking past those points, like maybe a C-section is recommended. Again, you have 5 other children. How's your recovery going to be? What are you going to have in place for that? I just think we do a better job of being able to see, especially because we've been a nurse before. So our perspective is not as medical. It's nurse and holistic person perspective. So I think that's really valuable. And then depending on where you're practicing, it's not always this way, but hopefully a midwife can be a little bit more hands-on throughout the labor process and be able to give a little bit more support than the OBs who are busy with surgeries, busy with a million other things that we don't have to do.
Yeah. Now, of course, I want to caveat this that there are OBs who practice very similarly to midwives, I find, and there are midwives who practice very similarly to OBs. So
Yeah.
I'm not saying that you just be like, oh, she's an OB or she's a midwife, she's going to be amazing. Because some midwives I've worked with and I'm like, oh my gosh, we're all going to die today. Or I've worked with OBs and I'm like, oh my gosh, like they want to be here from 6 centimeters on. Like they clear their schedule and they just make it and they really want to be there for the patient. They love that part of it. So obviously you want to find the provider that's right for you. But I get so many people in my groups that are like, well, I didn't want to have a midwife because she, what if something went wrong? I got diabetes or preeclampsia or something. And I'm like, no, like that's not going to preclude you from using them. Maybe you go see an OB for one appointment and then you go back to your midwives, right? I think
Yep,
a lot of
that's
people don't
absolutely right.
understand that there's like midwives, there's OBs, and then there's perinatologists, right? Like there are always these different levels of care that we're kind of like, we're kind of in the weeds here. Let's get somebody higher. Is there anybody above perinatologist? I think that's it. Or maternal fetal medicine is their new name lately.
Similar. Yeah. 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 And that's the thing is like a lot of these things, I can just make a phone call and be like, hey, maternal fetal medicine, what's our plan? But I can still implement that plan and be the primary person throughout the pregnancy journey. And that's really, really helpful, I think. And that's what it should be. We should try and keep ourselves connected with the people that we know and have a relationship with if we can.
Yeah. And I see midwives doing informed consent. It tend to be overgeneralizing all along the way, right? Like they'll at 36 weeks, they'll be like, hey, I am seeing that you might, your blood pressure is trending up a little bit. There is going to maybe be a possibility of an induction. I just want to put a little seed in your head so you can start to think about what's important to you and how we're going to balance that with an induction. We're going to see you next week, right?
Absolutely. That's exactly what I do.
Yeah, because whereas an OB, all of a sudden your blood pressure's high and you're like, we're going to induce you tomorrow. And they're just totally taken off guard.
Or they show up in labor and delivery. They're like, I don't know why I'm here. And nobody's
So
told them
true.
anything,
Yeah.
So yes, I agree with that completely.
I should say that one of the trickiest things is officially your labor nurse is not the one to give informed consent for the big stuff. Obviously, cervical exam or putting your blood pressure cuff on, we can do stuff like that. Definitely not for a C-section. We shouldn't be the ones really doing it for an induction. That should be a conversation that you have in the office or over the phone or something. But a lot of people are like, oh, the nurses didn't give me informed consent. But officially, that's not really our job. We should be the ones who catch it where we're like, this girl doesn't even know how or why she's getting induced. I feel like maybe you should have a conversation today.
Yep, absolutely. I feel like the labor nurses are there to help facilitate, to make sure it's happening. You have a little bit more time usually to give more of the background information that maybe the provider doesn't spend as much time on. And I think that that's really valuable. And you have the perspective of, again, that whole person that you've been taking care of, and you've been able to say, I don't think that this is what they really have been telling me they want, and you can communicate that to the provider a little better sometimes.
Yeah, that part's super rewarding for me. And also, just because you give informed consent to be induced, like we talked about with a Foley bulb, if you get into it and it's just miserable and you're starting to be like, I just want to have a C-section, my cervix isn't even opening, you can make another choice. It's not like informed consent and then you are on that train forever. You can be like, I want to get off this train. This train isn't taking me where I want to go. I can make a new choice. Obviously, once your water breaks, there's certain things we do that we can't roll back, but there's a lot of choices in labor and delivery where you can say, this is not working for me anymore. What can we do to change? And that's an opportunity for a new informed consent, right?
Absolutely.
It's tricky because a lot of people are like, I do not want to go home under any circumstances. But it's hard for us because we're like, 2 days at home could be a big difference for you.
I had a patient who we were sort of preemptively discussing like the need for induction. And she asked me that. She said, well, do people ever go home? And I said, great question. I said, most of the time, that's the patient that doesn't want to go home. Honestly, they're ready for the baby to be on the outside. I understand that. But it can be an option of like, this hasn't worked for 24 hours. Like literally nothing's helping. Can I go home for a couple of days? And there are scenarios that is not a good option, but there are many scenarios that it could be.
You know, Julie, I think one of the hardest parts of being a labor nurse is that I give birth all the time, right? As a labor and delivery nurse. So ultimately it doesn't end up as big of a deal. But when you are coming in, you're new. Do you have thoughts on that?
I just think as providers and nurses, we do this every single day, multiple times a day. So, an informed consent on induction, right? We might be like, oh my gosh, I've said this 7 times today. And that might change, the words we're saying. But if we keep the perspective of like, for this person, this is their first baby, maybe first induction. For this person, they have not experienced maybe ever being on the monitor, And so explaining some of the things that we're doing is important for me. I keep that perspective. I try to, that like, this is the most important day for them, even though I've maybe already caught 5 other babies today as a midwife. Like this is their time. And so that perspective helps me be able to like refocus and be like, okay, I need to explain all of this exactly the same way again. And that's okay.
Yeah. And as a patient, if you feel like your provider's sort of running through it, think of your job and something you tell people constantly all the time and how sometimes it's more clear than other times, right? If you work at McDonald's talking about the fry sizes or whatever, if you can always say to your provider, hey, can we just slow down and have a quick conversation about this? Sometimes it's been a long day. They're kind of quickly going through it. But if you say something like that, that triggers in them that you need a little bit more information. And I would say 98% of us are human. And when they hear something like that, they're like, okay, she really wants more help with this decision. And we are going to slow down and really help you. But sometimes, because we're human and you're human, we need that reminder that you would like a little bit more information and to slow things down. And that's A-okay to say as a patient, 100%.
Absolutely. Yep. We are humans after all. We're people just living the experience and getting through the journey, especially labor and delivery. That's a whole separate life-changing day, So yes. I agree with you. Absolutely.
Yeah. Guys, informed consent is so important. I really want you to take it seriously. I think providers are taking it seriously, way more seriously than they used to, because it really used to just be for a C-section. And that's it. Well, an epidural. But we really are doing a better job at it. But when you communicate what kind of information you want or things like that, I think it just helps everybody end up having a better experience and can prevent a lot of birth trauma when you understand that you are really in the driver's seat of this car. Thanks for coming on, Julie. Thank you so much. I know you're a busy midwife. You got to go catch some babies probably now, or deliver. We don't deliver.
Yeah. Yes. Thank you for having me today. It's always great to see you.
I hope you guys enjoyed that episode. I don't think we stress how important informed consent is. And I think a lot of times when you're in labor, you're just overwhelmed and you don't want to hear about it. So I think this is a good one to have your partner listen to and to just think about how you're going to implement when you're in labor, even when you're tired and you don't want to hear about it, because I think it can be really helpful in making the choices that you want when you're in labor and helping you feel like you are in charge of what's going on. Thanks for joining us on the Pulling Curls podcast today. If you liked today's episode, please consider reviewing, sharing, subscribing. It really helps our podcast grow. Thank you.